Marceaux. I'm one of the neuropsychologists in the hospital here at Audie-torium. And so what I'm going to be talking to you about today are some non-pharmacological interventions for dementia. I got started in being interested in this topic when I was a postdoc here. I had to do an administrative project, and one of the things that I wanted to do was to find a service for the veterans in our hospital who had dementia, who couldn't, who either weren't taking medications, weren't getting benefit from medications, or wanted something else outside of that. And so I reviewed a pretty vast literature on the topic, and so I'll be reviewing briefly a number of different interventions that I reviewed in my literature review, but spending the second half of my talk going over the type of intervention that we're using in our clinic here to just kind of run through some of the problems that came up and some of the positive outcomes from that. So I'll try to keep myself on track today. Get my timer going. Okay. So today I'll be talking about a brief overview of what dementia is and what the DSM-5 is now referring to as major neurocognitive disorder. I won't go into this too much since we just heard a pretty good summary of that in our previous presentation. I'll also be talking about a variety of different types of non-pharmacological interventions, and then going into a more detailed review of the cognitive type of interventions. As a neuropsychologist, those are the ones that I was most interested in. And then, like I said, implementing and outcomes of a cognitive program that I am currently running in our clinic here. So what is dementia? Basically, it is a syndrome that refers to a loss of some previously acquired cognitive functions. So it assumes that you've gotten to a certain level and there's been some level of decline. And the decline has been sufficient enough to cause impairment in day-to-day functioning in order to get the diagnosis. We've already reviewed some of these this morning, so I won't go into them in too much detail, but there's some common types or etiologies of dementia, Alzheimer's disease being the most prominent. In our hospital, we see a ton of vascular type of dementia, or mixed between vascular and Alzheimer's, just due to the nature of the comorbidities in our population here. But some other common ones are dementia secondary to Lewy bodies and frontotemporal dementia or degeneration as well. And as I mentioned a moment ago, so DSM-5 now refers to dementia as a major neurocognitive disorder. So if you hear that term, they mean the same thing. So just want to point that out in case there's any confusion on the topic. So how is dementia expressed? So historically speaking, when people were thinking about dementia, or when you would ask somebody, okay, what is dementia, they would describe it as somebody who's got poor memory or memory decline. But we actually know that depending on the etiology, there could be different patterns or different prominent features of that. So just to point out that memory is probably the most common thing, especially in Alzheimer's disease, but other forms of dementia may have language as a prominent feature or executive dysfunction as a prominent feature. But what we do know is that cognitive deficits or cognitive decline is one of the main expressions of dementia. And as I mentioned previously, functional deficits go hand in hand with that. So there's been a decline in functioning. But what often gets kind of overlooked, or is not necessarily overlooked, but isn't part of the diagnostic criteria per se, are these non-cognitive features. And these are the things that are often very disruptive to families and patients alike. And these are things like depression, anxiety, personality changes, behavior problems, things like that, behavioral changes. And so in thinking of treatment, you want to kind of target a broad array of these things, so you want to make sure to include all of these different areas, if you can, in your plan for them. So we just reviewed some of the treatments for Alzheimer's disease, and I think a lot of this goes with vascular as well. I'm focusing on these two because they're the most prominent in our hospital as well, in our population. But we just reviewed that there's no cure known right now. They're working on it. We know that there's no medical interventions that completely reverse decline in these types of progressive dementias or dementias that are non-reversible. And the medications that have been used, as we saw, have effects in some people, but not everybody. And they don't, as I mentioned, but they don't reverse the decline, and they don't necessarily slow the decline in everybody who takes them. So you have to think, okay, what else can we do? If medications aren't enough for everybody, what else can be done to help these people? So that's kind of where I'm going with the rest of this talk. So Douglas, James, and Ballard review, this was a little bit of an older review, but they did a nice job reviewing a ton of different types of non-pharmacological interventions. And so the way that they're grouped, I'm just going to review them the way that they had grouped them. So they grouped them first into the standard interventions. So these are the things that are most commonly found in treating Alzheimer's. I don't know what happened there. Did I press something?
No, you're good.
Okay.
Just press on things.
Okay. So these are the things that are most commonly seen in Alzheimer's types of care. You may see these in residential facilities. So I'll go into these in a little bit more detail in a moment. Some of the alternative interventions they reviewed are things like activity therapy, art therapy, things like that. So they weren't seen widely used across all settings, but they came up, I guess, on a consistent enough basis to make it into this review. Brief psychotherapies are used, so targeting mostly just the mood-related outcomes. So they studied cognitive behavioral therapy in dementia as well as interpersonal therapy and found some positive effects there. I'm not going into these in as much detail today. And then they had a group of other interventions. So psychosocial is one of them. And some studies you might find these brief psychotherapies kind of subsumed within other psychosocial interventions as well. Caregiver support is another type of intervention. And then cognitive is, again, one of the other interventions in this study. I think since this came out, it's becoming more widely researched as being applied in this population. So eventually, hopefully, it may become one of the standard therapies and not one of these other interventions. So in terms of the behavioral therapy, so these are most effective at reducing some of the behavioral symptoms. And so the way it works for a lot of them, if there's a particular behavioral issue going on, and again, a lot of these studies are looking at this in residential type of facilities, what they typically do is do this functional analysis of the specific behavior that's a problem. So they look at that behavior, they look at what are the antecedents, so what's happening right before it happens that might be causing them to have this behavioral issue, and then what things might be reinforcing it. So, are they getting attention for it? Are they getting some need met? So they can try to get that need met earlier or try to remove the antecedents so that they don't have these behavioral problems. I know that's a lot of technical information, but basically what they do is they try to figure out what's driving that behavior so they can reduce it, especially if they're doing something that could be harmful to themselves or other residents of their facility. So that's kind of a traditional behavioral intervention, but they also include things like muscle relaxation, progressive muscle relaxation, teaching communication between patients and caregivers, patients and staff members, things like that could be subsumed within this as well. So I'm going to go ahead and go on to the next. And so reality orientation is one that comes up a lot in the literature, especially when we're looking at some of the literature in the 80s and 90s. This was a very prominent approach. It basically refers to continual repetitive reminders about things related to orientation. So we're orienting them to themselves, where they're located, so the place, their situation, and so on. And so the goal here is to help keep patients oriented and to increase their stimulation. And that's kind of a basic level of what the goal is here. A lot of the outcomes that have been examined included looking at the MMSE. And so they find that it has been helpful at combating cognitive decline, so slowing the progression, looking at the mini mental status exam as an outcome measure. I think the main problem with that is that a pretty large amount of the items on the MMSE have to do with orientation, so they may be just overtraining to the task itself or the test itself. So it's hard to know if it really is slowing progression overall or if it's just making them better at answering those questions that they're being asked repeatedly. But what the research has found in the summaries I've read is that the longer program, so 8 to 40 weeks, is where it becomes more effective. And one of the other outcomes, which I guess is beyond just looking at the MMSE outcome, is that people who were involved in this type of program at home actually had more of a delay in terms of when they got placed into a nursing home type of facility. So there could be some benefit there in that realm as well. Overall, the research is pretty mixed, though, and so it has lacked some efficacy in some of the research studies. So one approach that came out to try to combat some of this efficacy is validation therapy. And so what they propose is that it's really not orientation that needs to be the focus. It's figuring out what's kind of behind their emotions, what's going on under the surface that's causing them to have complaints or depression or whatever the emotional component is. And so they propose that you kind of empathically listen, you provide support, you don't correct, you don't constantly orient them to things, kind of nonstop, as opposed to some of the reality orientation therapies. And some of the studies have found that they have actually had impacts on improving affect, or resulting in less negative affect is how it's often worded, having reduced behavioral problems as well. But again, results are mixed, and they need more research to establish efficacy as well. But it's one that's often, again, used in kind of residential facilities. I know I'm going through these fast, but I want to make sure every time we get to the ones that have better outcomes. Reminiscence therapy. Has anybody heard of this before? This is one that's pretty common. And it is what it sounds like. So you're reminiscing, you're discussing events or things from the past, kind of talking and thinking about things that have occurred in the past. And the objective here is to get them involved in something that's pleasant, have them communicating with other people, again, not correcting or orienting constantly, things like that. And again, the evidence here is mixed. So I think all of these programs so far, they've had lots of good elements, but the overall big picture has still been a little lacking. I'm pointing out one of the alternative interventions. I'm not going to go into the other ones. But the reason why I'm pointing this one out is because this is actually part of it. This is activity therapy. You can see that they have a pet here, so pet therapy wasn't in the review, but they have a little dog here, so they might be incorporating some pet therapy into this. They're playing basketball. And the main reason why I'm bringing this up is because one of the programs we're using kind of incorporates some of these other elements into it, so activity ends up being part of one of the cognitive therapies we're doing. Again, research is mixed if it's going to be a standalone kind of treatment. Psychosocial interventions are pretty broad-based, so it could include, like I said, psychotherapy. It could include a combination of different approaches. Signposting is one, getting the word out, educating family members, sending them to resources like the Alzheimer's Association website, educating staff, improving communication, and then just other general therapies. So if you hear about psychosocial interventions, it's really a non-specific term. It could mean a lot of different things. One of the really important things that was mentioned in the previous talk is the importance of caregiver support. So caregivers can experience a wide range of emotions, a wide range of stressors. There's a history of caregiver burden, and whenever the caregivers are stressed, that can affect the care they're providing to the person with dementia. And so it really is important to target these individuals to help give them the support they need. There's been a number of different studies looking at how best to do that, and really what they found is that any intervention is better than none. And that they've got pretty good results from a number of different approaches. So there's not one particular thing that's like the gold standard, but depending on the person's need, they may benefit from one or another. So this may include pharmacological therapy, psychotherapy, social support groups. They've actually done some research on online support and found that it's beneficial. But overall, what's happened is by engaging in these activities, they've reduced their depressive symptoms, increased their sense of support, and feel like they're better and more capable at providing caregiving to their family members or loved ones. So the last portion of this we're going to review are the cognitive interventions. And it's more than just sitting down and playing a game of chess. There's a lot of things that can go into it. So some different things that have been included in this include things like ADL and IDL training and a variety of different cognitive activities. So with ADL and IDL training, it's just like it sounds. You're focusing on improving activities of daily living, either basic or instrumental, depending on the level of functioning of the person who is being referred for the treatment. It's based on enhancing preserved aspects of their memory, so you're taking what they're already knowing, what they're already doing, and trying to enhance that, keep them staying as independent as they can for as long as they can, or if they've had a slight decline, trying to get them back to where they were with some supports. And so using procedural memory, so that's like riding a bike, tying your shoe, you don't think about it, you just do it. So they're using that memory system, which is less impacted, to help facilitate this in this program. So the outcomes here. So they found improvement in specifically the trained program. So whatever functional task you're training them on, there's improvement there. But they did find some generalization to related activities that were not trained. So there is a little bit of generalization going on. They did not see any impact on cognitive performance, which isn't surprising. You don't expect cognition to necessarily improve. You're not targeting anything cognitive in these interventions per se, other than just the aspects of what's needed for that functional task. And they did not find any significant improvement in quality of life, which is what I was a little surprised to find. You would think if they were more independent, they'd have better quality of life, but the research found a very, very little change in that, so nothing that reached any statistical significance. So moving along to some of the cognitive training programs. So cognitive training specifically is that you're training them on a cognitive task. So again, you're giving them, you have a certain target of a cognitive task that you're focusing on, maybe attention and maybe problem solving. You're teaching them a task kind of repeatedly so that they are improving on that one task. This may be done in a one-to-one kind of basis in a group. They've done some computerized studies, and so they found that all of these are adequate approaches, but the outcome, unfortunately, is that you only get improvement in the task that you're training them on. You don't get improvement across other cognitive tasks, so you're not generalizing to other areas of functioning, which is a weakness of this type of program. Cognitive rehabilitation, it sounds similar, but it's a little different. Rather than training everybody on the same task, you're designing individual interventions. So people are working with you to develop specific goals that they have in mind. So if they want to work on a specific thing, you develop a treatment plan for improving their particular goal. And you try to help them come up with different things that could interfere with them doing that. So it's really like a problem-solving team effort for both of you. And so what happens is if they have a caregiver involved, the caregivers have to be on board too, because the biggest effects are found when the caregivers are able to help implement some of this at home. So some of the guidelines, so it has to focus on individual goals. So their goals have to be realistic. They have to be meaningful for them as well. So if a goal was that, I had one patient who we did something like this with, and he wanted to help his wife be able to do some chores around the house. So we developed a goal of 2 chores he was going to help with, and rather than it being just ADL, IADL training, we came up with some cognitive strategies to help him be a little bit more, I guess, efficient at starting and finishing that activity on their own, rather than just having her direct him to it. So we had a list, basically a step-by-step list on how to use the washing machine, because he wanted to be able to use that at home. I couldn't train him to do that in my office. I can't go into his home and do it. But we broke down that task, and his wife would kind of reinforce that. So that was his particular goal. Usually whenever they've met one goal, you move on to the next goal they have. So it's really making it more individualized. And it doesn't have to be functional tasks. But you base what your goals are based on what cognitive strengths they have. So knowing, if the person has good attention, if they can read, if memory is not their primary deficit, you can capitalize on that, or knowing how they learn best. So you really make it individualized based on their cognitive strengths and weaknesses as well. The patient or client has to agree on it. So if they don't agree, they're not going to get as much out of it. They're not going to want to do it. And then there is a lot of flexibility in terms of how it's implemented. So let's talk a little bit about those ways. So the research basically shows that it's been done in outpatient and residential facilities. In terms of residential settings, usually it's the staff members and the patients both agreeing on a goal, and their caregivers may or may not be involved with that. Some of the studies looked at individuals on their own, but they found a lot more positive effects if their family members are involved in the treatment program, because they can reinforce this at home and make sure that they're doing these things on a day-to-day basis. It's been used as a standalone intervention and as part of a larger intervention, so maybe they're also going to a day program, or they're also using medications, or they're also involved in a reality orientation program. So it could be used in combination with other things. And a few studies have also come out with some computerized programs where they can log in and look at their goals and work on it online. So the areas that this is supposed to address are their own personal rehabilitation goals, specific strategies, so going over aids or coping strategies they can use. What are they already doing? Can you build on those? Building on their memory skills that they still have remaining, so kind of those overlearned things or recognition memory, whatever is their strengths that they have. It may involve continuing to practice ADLs or other skills that they have goals in mind for. And having them create new routines, because as things become more routine, it takes some of the memory out of it. So it's not as debilitating if they can have a routine for it. A lot of the programs address attention and concentration, because if you have better attention, you might be able to encode a little bit more information, you might be able to engage in the task longer. So some of them have incorporated some specific attention type of programs. And then stress management, because again, mood is that other area. So it's not just cognition, it's not just functional, but it's also those non-cognitive type of signs as well. And then family involvement. So again, best effects were when family was involved. So some of the procedures, so I'm not going to go into all of these, but I'll kind of go through a couple of them. So space retrieval is one that's used in a lot of these programs, especially if a person's asking repeated questions. So if they're always wanting to know, what time are we leaving or what are we doing today, you can teach them through space retrieval a technique that's used to kind of teach them to go to one particular place to get their questions answered. So if you have a memory board at home or a calendar that's posted somewhere, it's a lot easier for them to learn to go check the calendar than it is to learn the new schedule for every single day. Because that's going to be changing. The calendar is always going to be there. So with space retrieval, you can, every time they ask, tell them. But you can actually kind of implement this where you're telling them a lot more frequently at first, and then you kind of space it. So you wait a longer time and see, how long can I wait till I have to remind them again? And over time, you have to remind them less and less frequently. I could probably give a whole talk on just how to do some of these techniques, so I apologize if it's a little too much of an overview there. Some of these other things, the dual cognitive support, this is giving them cues at learning the information and then retrieving it. So it means you're going to give them reminders or cues or organize information on the front end, and then also give them the cues on the back end. So you're kind of helping out with their memory retrieval in that aspect. So it goes along the list here. A big part of it is also teaching compensatory strategies. So teaching them how to use a calendar or a diary, creating a memory book where they can go to that one place to get all the information they would need. If they're in more advanced stages, you may have to post signs on the door to let them know where things are located. And also come up with things that can help with tasks. So if they are, like my gentleman that I was mentioning, who wanted to be able to work the washing machine, having a list posted right above the washing machine that has all the steps they can follow. So it can really widely range because it really is dependent on what their goals are. The aids that you create, however, are only going to be useful if they are going to use them regularly and they understand what they're for. So if it's something they're going to do once a month, it's not going to be as helpful versus something that they're going to do every day or every other day. So some of the outcomes here, they found for the interventions that included a processing speed intervention, they did have improvement in processing speed 3 months at 3-month follow-up. They had improved face name associations. Again, some of the programs, that's what the participants wanted to work on, was being able to learn names better. People were generally more oriented. They had, if their goal was increasing some functional skill, they had positive outcomes in that. So it really looked as though whatever their goals were, they were maintaining that at least 3 months out. But they didn't really track how often they were continuing to do it or whether or not their family members were continuing to prompt them regularly. But again, they did, generally the studies found that those who had caregivers were more likely to have the positive outcomes at 3 months as well. So it may be that they're providing more support kind of in between the treatment and the follow-up. What's important to me though is that the patients themselves improved in terms of quality of life. So regardless of, the fact that there's no cognitive change other than processing speed or, however they did, they actually felt like their quality of life had improved as a result of engaging in these things. And their mood had actually improved as well. And that was, again, maintained over 3 months. So getting into the next, one thing I meant to mention here is that most of these studies have been involved with individual programs because it's an individualized kind of treatment. It's been a one-on-one kind of intervention. There was one study that came out looking at a group intervention, but they had not yet published their outcomes at the time I reviewed it. And I don't think, I'm trying to look and see, I don't recall exactly what their proposed outcomes were, but I think they were similar to some of these. So they were looking to see if they could do a similar program in a group session. The Cochrane review in 2003 found insufficient evidence for this program as a standalone intervention, but in the more recent one, I think they're finding a little bit more support, and more studies have come out since that 2003 review. But one of the ones that came out as being a very promising intervention in the most recent Cochrane review was cognitive stimulation therapy. And so this is one that actually has been mostly conducted in a group setting. And so if you're thinking of, how am I going to reach the most patients and get the most care out to the most people, group is a good way to do that. And so this is the direction I ended up going whenever I was deciding on what to do. So I know a little bit more about this one than probably all the others. This is based on theoretical concepts of reality orientation training and cognitive stimulation. And so you're taking elements of that, and you're taking elements from some of the other interventions and putting it together into one kind of comprehensive type of intervention. It takes a very global approach, so you're not focusing on one particular cognitive skill set, you're not training a cognitive skill, you're not training any functional skills, but you're kind of broadly getting them to use different aspects of their thinking in this program. So you're getting them to use attention skills and language skills and even memory in the process of some of these topics. You'll see how these things come out. There's also a psychosocial piece to this, because we're trying to also not only get them to use their thinking skills, but to improve their quality of life, their self-confidence, improving their mood, and so on. So to me, those are the main outcomes here, is trying to make sure we're improving quality of life for these individuals. It's a relatively, most of the studies have been a relatively brief version of this. And so these have been typically 7-week therapies, so the sessions usually are twice a week for 45 minutes. Although there's been some flexibility in how that's been applied, and I'll go into that in a little bit more detail. Some of the more recent studies have found that maintenance stimulation therapy has been also helpful, and so that means just extending this beyond the 7 weeks. So the key principles of cognitive stimulation therapy. So one is mental stimulation. So as you can guess, the aim here is to mentally stimulate people. Everybody in the group would have different strengths and weaknesses. You're wanting to try to make sure to challenge all of them on some level. Trying to get them to exercise the skills they still have and stimulate different parts that maybe they haven't been using as much. Language being one of the prominent ones. A lot of people end up sitting at home, isolating, watching television. They're not using a lot of those thinking skills that they would have been using, as a younger adult when they were working, and so on. So mental stimulation is one of the key principles. New ideas, thoughts, and associations means that you're continuing to encourage new thoughts, new ideas, getting them to think about new topics without it being a memory test. So it's more like, what's your opinion of things? And we can look down the list, opinions rather than facts is one of them on here. And that's because they can't be wrong if it's their opinion. You can present them with okay, this is what's going on in the news. What do you guys think about that? And that's kind of how we promote discussion and formation of new ideas. It's really amazing to see kind of how these conversations go. Using reminiscence, so reminiscence is part of it. A lot of them, I'm going to go over some of the feedback they've given, and they really enjoy that piece of it as well. I'm not going to read through every single one of these, but I just want to pick out a few of them. So person-centered is one that's really important to me. So you're seeing the person first. We don't really sit around and focus on the fact that they have dementia. Most of them are aware of that. Some of them lack some insight, so they may not remember that they have as significant memory problems as they do have, or cognitive problems. The people who I've been working with have all gone through testing, have already received feedback on their diagnosis, so they know that they have that, but they're not there to focus on that. So it's not just talking about, okay, what memory problems do you all have? It's really giving them something else to do. One of the other things that I think I try to emphasize to them is that they have a choice. So we present them with different options to do each week, kind of within a theme, and that they're supposed to have fun doing it. So it's a really fun program. So what is not part of this therapy, is that we're practicing situations or activities that, like they do in cognitive rehabilitation. So we're not overly practicing things over and over again. We're not, as I mentioned before, we're not training a specific cognitive task. We're not training specific functional skills. And caregivers do, they're not really involved in this intervention other than some of them depend on them for transportation. We do ask them some feedback after the intervention so we can kind of see what things they may be noticing at home. But they're not actively part of the therapy. We're not asking them to do anything at home with them, like what's typically done with cognitive training or cognitive rehab. So, they come in, they do their thing for that week, and then they go on back home. So as I mentioned, they had a more recent Cochrane interview that came out. It deemed cognitive stimulation as an effective intervention. And what also came out since then is that the UK, they have, I wrote down the name of it, so they have their own board in the United Kingdom. And the reason why I mention that is because this program has been mostly developed and researched in the United Kingdom. But they actually have a board, the National Institute for Health and Clinical Excellence and the Social Care Institute for Excellence have both determined that this is a recommended treatment for people in their country that have dementia. So it's being more widely applied there, I think, than it is here. I did notice just this week that there is a clinical trial starting in January of next year where they're going to be looking at this in, I think it's in Los Angeles. But overall, the studies have been pretty positive. So I'll go kind of through these a little bit. So the length and duration has varied. So most of them involved the 7-week program that happened, so they had 2 sessions a week for 7 weeks. But others had different amounts of time spent per session or different number of sessions. All of them have been pretty effective, so they haven't found like a dose-response kind of relationship. There's been no, as I said, no dose response. There's been no effect on cognitive functioning per se, so they haven't found improvements in cognitive functioning, but the studies have found that there is less of a decline over time. So it's kind of inaccurate to say there's no effect at all, but it's not improving cognition. But it has been one of the most widely researched programs. And this is just a number of references that have cited the specific studies or the specific program that I'm using, so cognitive stimulation, which was developed by Amy Spector. So here's a number of them. It's been found cost-effective and beneficial, improving quality of life as well. And so this is a couple graphs from one of Spector's studies. I kind of recreated it, but one of them is looking at mini mental status exam, because that's often used in some of the outcome studies here, and then ADOS-COG. And so both of those compared to a control group, which received treatment as usual, had more of a benefit, whereas the other group had a slight decline. So this was statistically significant finding. And then what you see also, little pointer, I don't know where it went, but the other side is quality of life. So quality of life as a result of being in the study goes up, whereas treatment as usual continues to decline. So 0 is where there's no change at all. I think my clicker broke, but 0 would be where there's no change at all. Above the line means a positive improvement in this case because they're rating higher quality of life. Below 0 means a decline in quality of life because their scores have gone down from pre to post. If that makes sense. So some of the findings that they've detailed, so improved ability to use spoken language. So they find in a lot of their studies that the items related to language have the biggest improvement. That's on the ADOS-COG. Caregivers report increased engagement in conversation, so they're speaking more, they're more fluent in their speech, they're engaging more outside of the therapy than they were beforehand. And they're not finding any specific memory improvement, so they're just kind of generally saying, oh yeah, and I think their memory might be a little better, but nothing really specific. Participants, that was caregivers, participants are feeling like they are better able at paying attention and concentrating as well. Whoops, I didn't realize that was on that slide, okay. Quality of life, as I mentioned, is another outcome that they had. So functioning was weakly correlated with higher quality of life in the control participants. And then pre-morbid functioning actually made a difference. So where they were functioning before the intervention did kind of have a relation to what happens at the end. Yeah, that's pretty much all I was going to say there. So let me go through this. And then the final thing here is mood. So they looked at how does this program affect one's mood. And what they find is that there wasn't a huge association between changes in mood of caregivers or caregiver burden. So that's one area where I think there could be some area of improvement. So if you can find an intervention for caregivers to have at the same time as the person who's involved in the stimulation, so you might be able to target both of them at the same time. So that's kind of an unfortunate finding there. So overall, kind of thinking about all these different interventions, the standard techniques have mixed results. They are not always effective at improving quality of life, and some of them only improve the things that they're specifically targeting. Among the cognitive intervention, there's some variability, but cog rehab and cognitive stimulation are the two that have probably shown the best effects on mood and quality of life of patients, not necessarily caregivers. All right, any questions? I'll just pause for a second because I know I went through a lot before I get into kind of what we're doing here.
Is any of that looking at the earlier younger onset?
Most of the, that's a good point. So most of the interventions we're looking at mild to moderate, and some of like the cog rehab ones are specifically looking at more mild. And then the cognitive stimulation looks at mild to moderate.
I'm talking about the age.
Oh, the age. I'm sorry, I thought you meant like, no, I don't think I've seen it. I think they report ages, but I don't remember seeing a big association with age. I think it was more associated with kind of disease severity, which would likely be related to age, but they weren't targeting that specifically. Yes?
Does Medicare cover any of these interventions?
You know, I'm not sure. I think what, in the UK they have a different medical system, they have a different system altogether. In the VA, you know, we have kind of the luxury of having people here who are receiving care, so we don't necessarily have to focus on those as much. But that's, I think because it hasn't really been applied as much here, I don't think that it's one of the programs that I've seen kind of being recommended in the US yet. But yeah, that's something I think to look for in the future. And I think when I was looking at that study that's coming out, I think that's probably one of the first things that has to happen before it starts being probably covered. But it's a good question. Okay, so just to go into this particular program a little bit more, well, let me kind of thinking of your question again. You know, this is something that's being done in a residential facility where there's already rec therapists or people who are already there engaging in specific activities. This could be something that would be subsumed within that because it is kind of a broad program that could be done depending on the level of training that a person had. You know, you don't have to have a PhD to be able to administer this. You just have to be able to know how to work with people with dementia and understand kind of the goals of the program. So I think it has avenues where it could be used by people more broadly. So these are this is the traditional cognitive stimulation therapy setup. So they have 14 sessions, each with a different topic. The way that it's done is, again, 2 sessions a week for the 7 weeks. Oops, I went too fast. The sessions follow a specific pattern. So even though the topics change, you know, people that have cognitive problems like this, they really benefit from having structure or routine. So every session is structured in the same way. So you have the, you know, a similar introduction, you have activities that kind of get you going every time. They suggest doing a familiar activity like a song that everybody knows, and I'll talk about how that works here in our system. And then the main activity is the topic that changes each time. And the way, just to give you a couple examples, well, I can tell you that of these, my favorite ones are the session 8, being creative. That one's one of my favorite. As well as the word games, so session 7. Those are the 2 that I think are a lot of fun, and physical games. But I figured I'd put a couple on here just so you can see what might happen. So physical games, you could come in with a few different tools. For example, what we did last time was we did the floor basketball because everybody likes the Spurs around here. So we kind of took our shots to see who would do the best and you know, really adapt to the people who were there. So some of them had strokes and only had use of, you know, one side of their body. So it, you know, it can be a challenge depending on who's there. Part of it also is to promote discussion and formation of new ideas. So we're talking about, okay, what are people's favorite teams? What did they do as a kid? What kind of sports did you play? What sports do your grandkids play? So keeping them also oriented to what's going on now. So having a good discussion of these things. A sound topic might include listening to music from eras whenever they were younger. Playing sound bingo, so they're listening to sounds on a CD, trying to match it to pictures on the board. Just depending on the level of functioning of the people in the group, you can really kind of adjust it accordingly. Using money, so this is one where it has really depended on the level of functioning of the people in the group. So if a little bit higher functioning, we might pull out some groceries and have them, okay, imagine you're going to prepare a breakfast. What would you, what things would you pick here? We've also had people bring in like their, a few of them, met people overseas or, and had been stationed overseas, so they brought back money from there. So they brought in some money and we're looking at, okay, how does our money compare to this money that you brought in? Or looking at, how much things have changed in terms of cost. So, how much was your first house versus, how much a house goes for now. So I brought in like an advertisement for a house for sale. So just having discussions on just changes over time related to money. Number games would be things like dominoes or Yahtzee. So again, having to modify these based on the level of functioning that a person is at. I think one thing that was a challenge for me is that the book itself, so if you purchase the treatment manual for this, it has a lot of great suggestions, but there's no materials. So you have to kind of be creative in going out and finding materials to use and finding things that are going to be appropriate. So you don't want to treat them like children or anything. You want to find activities that are age appropriate, but not overly challenging. So that is a challenge. So in terms of implementing this program in the VA here, so first was, we had to figure out, okay, who's appropriate for the group, where are they going to come from? And so primarily we had people coming in from the neuropsychology service, so people who've gone through testing, we know their cognitive strengths, we know a lot more about them, and so we've been able to identify people that way. We've looked at kind of doing a pre-treatment assessment so we can ask them questions about their mood and quality of life beforehand so we can see, okay, is this actually helping? Because we know how the studies went in other countries, but we don't really know how it applies to our veterans here. And so we're looking at pre and post assessment just for quality purposes of our program. One thing that I didn't think of when I first did this is where's this going to be held and where am I going to get all the materials for it? So that's a challenge in and of itself, trying to find space is a challenge. But it's actually worked out pretty well. And then we'll talk about some other considerations and barriers. In terms of the pre-post assessment, so what I'm doing, this isn't necessarily what's going on in all the research studies, because I'm doing this as a clinician, trying to make sure I'm doing something that's actually helpful to people, not a randomized control trial. But I'm looking, some of these measures are things that we give already as part of our cognitive battery when they come in for neuropsych testing. So we're doing a brief cognitive assessment using the MOCA, a little bit more of a thorough assessment using the R-bands and TIFL, so the Texas Functional Living Scale, and then some mood and quality of life measures. And then when caregivers are available, I'm asking them some of the information too, because they may see something that the patients aren't noticing or that I might miss. And then at the end of everything, I'm asking the participants of the group and their caregivers, okay, what did you like about it? What didn't you like about it? Just to get their overall impression, since it is something relatively new to me and new to this facility here. So in terms of resources, so the treatment manual, like I said, has a variety of suggestions, but you had to go out and find things. So first you have to know who's going to be in the group to know what level of functioning they're at. I had to practice some of these activities to make sure they'd actually work in the group. And then I always ask them for feedback, so I know, okay, how did it work? Did you like it? What didn't work about it? So we can adjust it the next time we do a group. I'm not going to go into all these, but you can, if you end up doing something like this yourself, these are some things to keep in mind. We were trying an inpatient group. We didn't quite have enough people, so I'm not going to go into any outcomes from them, but one of the biggest problems there was that they have TV shows in the morning that would interfere with doing a group in the morning because they want to watch their shows. And there's other activities on a unit that are going on. So they're having their, different levels of care by nursing staff. So you had, in the afternoon, we had to end up doing a group in the afternoon, but there's other things that you're combating against. So like fatigue, sundowning, those kind of things. But the positive thing is there's no other activities on the unit. So there's a lot of things that can come up if you decide to implement something like this. The biggest barriers to treatment, though, with the outpatient group is that they depend on their caregivers for transportation, a lot of them. So, a lot of people wanted to do the group, but they just couldn't get here because their caregivers work and we had no ride. So trying to help figure out a way to get them here in spite of that. Maybe depending on their children to bring them, or other transportation services. Health factors are also interfering. We had one patient who was supposed to start and he had a heart attack the day before the first group, so that kind of put a damper on him coming right away. So different things interfere. With the inpatient group, we were trying, nursing staff has a really busy schedule, and if they have to get them in the bed, from the bed to the chair, it's a lot harder to kind of work around their schedule in that way. So just to briefly go over some of our outcomes. So for our group, the mean age was 70, and the education was just slightly under 12 years. So far, we've had four Hispanic patients and then 4 white non-Hispanic patients complete the group. We've got a few others who are currently in the process of going through it right now. Their diagnoses include things like vascular dementia, dementia NOS, so not any specified type of dementia, Parkinson's disease dementia, and a mixed Alzheimer's and Parkinson's disease. Informants typically were spouses who saw them every day, but not everybody. A couple of them had children or a friend as an informant or caregiver. I just mentioned that. So in terms of their cognitive status before and after, so MOCA didn't have much of a change. As I said before, we're not expecting any major changes in cognition. I don't have a control group to compare to, so I don't know what it would have been if they hadn't been in our group, but slight improvement, but no major changes there. TIFLs, again, with only 8 people completing, I'm not running any statistical analyses on these yet. It's a little premature, but they're within a couple T-score points of each other, so no meaningful change in functioning. With RBANs, things are pretty stable. So these are kind of the overall index scores. So they're pretty much staying in line. There's no drastic declines or improvements. A little bit of an improvement in immediate memory and attention if you're looking at the yellow line being post. If we break those into the individual subtests that we have, you see in the list learning task, that's where they're hearing a list a few times. Okay, yeah, I forgot it's not working. So it's that first one here. That one's got the biggest improvement, and then line orientation and digit span, those are the other ones that have kind of improvements, and all of those could have something to do with attention, I'd say. No major changes in depressive symptoms, but there was a slight decline in anxiety-related symptoms. A lot of them had comorbid psychiatric disorders, PTSD being one of them. So it could be related to some of that, that they were maybe anxious about being in a group setting beforehand and kind of acclimated to that, or, I'm not really measuring these underlying factors right now. In terms of quality of life, the scale's a little deceiving. It goes up to 50, so it's actually, the bar would be a little bit squished. I haven't noticed that beforehand. But there is an improvement in quality of life as reported by the patients and caregivers, which is my main outcome for doing this, my main reason. The thing I want to spend a little bit more time on, and then I'll break it up for questions, are what are the patients actually saying? This is the part that's most interesting to me. So we asked all the patients, what did you like about the group? So I'm not going to read every single thing they said, but you can kind of look over these. And one of the things I really like, so the program recommends that you have this song that you sing at the beginning of every group to kind of orient them to it. And none of the veterans like that. None of them want to sing, which I'm not surprised. I don't want to sing. But so they said, one of them said, it's a good group, I'm not a singer, it's not a singing class. He just was very focused on the fact that he did not want to sing. But everything else he said was good. Another person said they really liked the games, the explanation, they liked being in a group, they liked talking with other people, they liked the atmosphere, it was interesting. So all, in my opinion, pretty positive feedback here. One of them said he would like more ladies in the group because we have a predominantly male population. Things that they disliked about the group, again, the same individual said, I'm not a man who sings, I don't want to sing. So that was his biggest complaint. But nobody else had really anything too negative to say. One of them said it didn't last that long, so they wanted to be there longer or come more often. Or maybe have more weeks, and they wanted more. I asked them, if it was available, would you want to do this again? One of them said no, and he was probably the lowest functioning guy I had, but it showed me he had a little bit of insight there because he probably didn't enjoy it quite as much. He'd often kind of take little naps in the middle. But everybody else said, yes, I really would want to do this. Can I come to the next group? And we've actually had about 3 or 4 of them who have actually repeated it, who come back, another time to do it. They wrote down other comments. And I had just a space open for other comments, and so one of them said he was embarrassed about his mood lability. The last couple sessions he had cried a couple times in discussing something related to his son, so he got embarrassed about that. Another one said, that he felt like he wanted us to pick games that were more challenging. He was one of our higher functioning people in the group. He wanted things that were more challenging, but he really liked being able to share about his life and how they got to where they're at now. I asked the caregivers, okay, so did you notice any changes in mood over the course of this, them being in the program? And what they said is they don't know the difference between mood and cognition really, so I take it as, whatever they give me, I just write it down. But some of them said, he's more relaxed, he looks forward to Fridays, because we have our group on Fridays. They're happier on Fridays, more talkative in general, more alert. So those are all, to me, good things. In terms of changes in cognition specifically, it's not how I worded it to them, but that's generally what the vibe of that question was. So one of them said, he's better at participating in conversation. He spends more time discussing the newspaper or TV programs he's watched. So a lot of them are talking about conversation being the biggest change in their thinking skills day to day. They're more engaged with their family, which is good. In terms of changes in daily living, not a ton of things here except focusing on a couple of them were more apt to helping out around the house. So a couple of them had made mention of that. One said he's bathing more, so he's got somewhere to go. It's not such a struggle because he wants to go and he wants to be nice when he goes there, so that was a good thing. Nobody discussed any major burdens, which was one of the things that I was most worried about. Am I creating more of a burden on caregivers who already are stressed enough? And most of them said no. It's not a burden. I like bringing them. I can go get my hair done or go shopping while they're at the group. It's great. And I didn't really mention this, but the way we ran our group, because we didn't want to create more of a burden having them come twice a week, we actually had them come just on Fridays for an extended session. So they had a good hour and a half, 2 hours to go do something while they were at our group. So that it was a good amount of time. And some of the caregivers actually said they wish the sessions would be longer so they could go out and do more things during that time. So they really need to respite, I think. And then, a couple of them said, if you're going to do another group, can you focus on, improving their day-to-day activities? So, some of these people, I actually worked with them for a session or two after the group was over to help them address some of these other needs they had, since it was kind of outside of the scope of what the group was doing. And then I think the last thing I want to mention are these other caregiver comments. So I really liked what this one woman said. She said, I've seen some progress in his behavior, mood, and some motivation. He still forgets things, but I believe that with God's help, the medication and this therapy is helping him. Thank you very much. So she had handwritten that and left it kind of in with the front desk for me. And I think that was a really good testament to all the things that she's working on at home, the medication he's getting through his providers at the gym clinic, and then engaging in this therapy. I think all those things together were kind of helping on those fronts. So anyway, I had a video, but we know how those go around here, so I'm just going to skip that. And it was just a brief minute video. If you want to look it up on YouTube, it's Maintenance Cognitive Stimulation Therapy. It kind of shows a brief overview of what one of these sessions looks like in the middle of it. It's by a program that's doing this in the UK. Basically, in my group, the initial data suggests that it is helpful in improving their quality of life, and the patients and caregivers are giving good qualitative information. They don't have enough people who've completed it to get all the quantitative data that we would need to look at to see if it actually is effective. But that's kind of one of my future plans, is to keep working on that. Maybe implementing something for the caregivers to do as an option if they want to stay and get some other support, but it seems like a lot of them like the respite to go out and do other things. But keep working, I guess, at figuring out ways to improve this program to make it appropriate for veterans, because not all the activities may be appropriate. Just looking at the manual. So we've been adapting things along the way and getting really good feedback from them. And it's a lot of fun for me as a clinician providing this service as well. So what questions do you have? Yes?
Are you using other disciplines in the programs, like speech therapy and occupational therapy?
No, right now it's just myself and maybe one of our residents. But in the future, we've talked about maybe using people from Geriatrics if they want to help do something with the caregivers while we're doing it. That's one of the things that we're thinking about doing in the future. But nothing with speech, yes, if we ever doing anything with other disciplines right now. Nothing right now. But that, I think it could be used in that way too. Anything else? All right, well, thanks so much for hearing my presentation. I hope you took something from it, and if you have any questions later, feel free to approach me or email me. I'll be here all day.
Can you put the list back of the things that you did, like the physical games?
Oh, the list of the different activities?
Yes,
sure,
please.
yes. And I'll tell you that if you look up, all these things are on the website for the program. I have no financial, benefit from going over this program. This is one that I really just chose because it seemed appropriate. Sorry, I'm trying to get there. But they have their website is cstdementia, I think .com or .org, I'm not sure. But if you look up cognitive stimulation therapy, it's one of the first websites you'll find. But yeah, so this is the different sessions. All right.